From the heart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, I'm Bob Harrington, and I'm here at the American College of Cardiology meetings in Atlanta. I always love to use these meetings as an opportunity to catch up with friends, with colleagues, talk about what they're working on. And for those of you who have listened to the podcast for a long time now, you know that one of the things I really like to do is to talk to physician writers. Sometimes it's fiction, sometimes it's nonfiction. And today we're going to talk to a colleague from Stanford who has written a new book on heart disease and cancer. And we'll get into a little bit of that in a moment. So I'm here with my good friend and colleague, Mike McConnell. Mike is the Chief Health Officer at TOCU, and you're also a clinical professor of medicine at Stanford still.
Yes.
Still seeing patients and still reading images.
I am.
Excellent.
Yeah. Great to be here, Bob.
Mike, I know you sent me a copy of the book, and I really have enjoyed reading it. It's a nice read and provocative title. Tell us what the title is.
Sure. The title is Fight Heart Disease Like Cancer.
So that grabs your attention. You're a preventive cardiologist. You're also an engineer. And we're going to kind of unravel both of those as to how you came to this. But one thing I really liked is you use both stories and evidence. As I would expect from a clinical scientist, it's heavy on the evidence. You're not saying anything that's not based in the literature, but you're telling stories. And there's some pretty powerful stories. One of the early stories is the unfortunate death of your father-in-law, because that seems like it profoundly affected how you think about this.
Yeah, and I would say that was sort of the first time I thought I need to write a book someday because, my father-in-law, my daughters are only 10 and 13. He, was a very prominent scientist, actually developed a lot of cancer detection blood tests and was quite interested in doing the same for heart disease. Unfortunately, not particularly good about seeing the doctor. And he gave a big talk, was on a van back from the talk. And when everybody got off the van, he was still sitting there, had sudden cardiac death. People take cancer quite seriously. Heart disease kills more people than cancer, yet we don't seem to take it as seriously as we should. And so, and that happened on my watch in many ways.
Yeah, you bring that up, that with your wife, his daughter, obviously, your daughters, you bring up this notion that it happened on your watch. I think you used that phrase.
Yes. Which in the book, I talk about some of the things I tried to do. On the other hand, it reinforced that we have to sort of give tougher talk to our patients, that taking a few more extra steps or dropping a donut here and there from your diet is not really enough for many people to prevent this catastrophic disease. So
speaking to talking tough or making changes, go ahead and ask your patients, would you rather have heart disease or cancer? And uniformly, people pick heart disease. So you started talking to people in the language of the cancer diagnosis. Talk a little bit about that.
Sure. And I think that's a great example of where sort of the science and the stories came together.
Yeah.
Because as I, started my research career, a lot of it was trying to develop new tools to image stenoses in your coronary arteries. And I think we now recognize that's really late stage disease. And so as the field was evolving, my research was evolving towards, can we pick up earlier plaque? And then, as you know, whether a plaque is biologically active and inflamed and all those became more important. So, we shifted more towards molecular imaging. And then I started realizing I was imaging more like an oncologist, right? You do a PET CT scan because, yes, there'll be a tumor there, but is it growing? How active is it? We should shift everybody's focus more towards early disease detection and how do we reverse the biology so that it never becomes late-stage disease. So we don't have your father-in-law having a sudden MI because we know symptoms, some people are lucky, they get the symptoms. We've got great stents and surgery for when people come in acutely. But as you know, half the people don't make it to the hospital with the heart attack. So we really want to be much more upstream, think of it as a biologic disease, and learn from how cancer is much more about early screening, detection, and then if you find something, reversing the biology, making it benign. So, right, my discussions with patients, a coronary calcium scan is very similar to a mammogram. The story in the book that when a patient had a high coronary calcium score, we started him on a statin, and comes back a few months later and said, I stopped it. I thought if I did a little bit more physical activity, a little bit healthier diet, I'd be fine. Maybe I overreacted, but it was very impactful where I said, you have to think of this as cancer growing in your coronaries. And
you tell that story.
And a very strong visceral reaction. And that, that's part of the reason cancer is called the C word, right? People don't even want to use the whole word because of its impact. And so in many ways, I'm trying to, up-level people's understanding of heart disease and really empower them that there's a lot more we can do for early detection, and to sort of stop it in its tracks if we find it.
Well, and that's how you talk about it. You break it up into, you do talk about early detection, you talk about prevention, you talk about treatment, and it all sort of rolls together from a parallel to cancer, which I found really interesting. And the way that you use the language about a tumor growing in your artery is like, that grabs you.
Maybe it's unfortunate we switched our medical term from atheroma, which has the oma tumor, which is how it was initially described, to plaque, which doesn't, that more sounds like what accumulates on your teeth.
Yeah.
Rather than...
And then you have to scrub that away. Right.
Exactly. But the prevention part, I think, between the Heart Association, the ACC, and the cardiology community, I think, has really tried to educate public around prevention. I think one of the things I do to try and reinforce prevention is almost everything you do to help prevent heart disease is on the American Cancer Society website that also helps prevent cancer. So physical activity, healthy diet, avoiding, cigarettes, excess alcohol. Maybe that helps with the motivation to think that you're helping to prevent both. And then right on the screening and therapy is where I think heart disease can learn more from cancer.
Let's unpack some of these things. Just the other day on CNN, the lead story was growing detection of cancer in young people. And you've seen this now. Colon cancer is getting detected at a younger and younger age. And these are very aggressive cancers that are being detected. And the lead story was about the potential biologic reasons. And one of the things people talk about is inflammation. And they talk about inflammation from the perspective of metabolic disorder, obesity, diabetes. And it seems to all track. And as you said, you've started listing off the AHA's essential 8. And the Cancer Society talks about the same things.
Yes. Yeah, exactly. I mean, one of the big overlaps why they think, healthy diet, physical activity, obesity are strong risk factors for both is that they promote sort of more of a systemic inflammation. And the more that we're understanding that inflammation in the immune system, there's a lot more awareness of the impact of that in cancer and cancer therapy, but we're just sort of at the beginnings of more immune therapy-based targeting inflammation for heart disease.
People like Paul Ritka, Peter Libby have been talking about this for years.
Right. They get their stories.
Right.
I worked closely with them when I was at the Brigham. And so, lots of still untapped potential there.
A lot of untapped potential. Let me ask you a question that I was thinking about as I was reading it, that in cancer care, it's getting more and more precise, meaning that we're finding more and more of the biologic pathways, whether it's genetically, people are checking the tumor genetics to then decide what therapy is going to be used. Cardiac disease, atherosclerosis, is a little more complicated.
It is.
And do you think the analogy falls apart over that? Or do you think that the analogy still has relevance with that?
I think it's a great question. I mean, there's a lot of interest in more, precision medicine.
In fact, it's not even like breast cancer or lung cancer anymore. It's this pathway cancer.
Yes, even within individual cancers, right? You're looking at what are the genetic drivers of those, and then there are the targeted therapies for those.
And the clinical trials are being done that way.
Yes. Yeah. I mean, it's interesting, but certainly we have the challenge or maybe opportunity and interventional colleagues like yourself, maybe have more opportunity to do this, which is, we rarely access the underlying tissue of atherosclerosis to sort of make some of those determinants. There are aspects, say, around diabetes and obesity, where they're trying to learn different genotypes and phenotypes, or what are the drivers so that you can more optimize therapy. On the flip side, I would say one of the drivers of writing this book is we still have a long way to go to just getting people with the basic sort of broad guidelines that we have.
Yeah.
And yes, there's some additional benefit of more precision, but we still have to sort of raise the boat to or what the right.
Well, let's start on the detection piece, because you talk about we need to have cardiac assessment detection. Learn from the cancer docs, or not even that's not fair. Learn from public health around cancer. That whether it's a mammogram or some other imaging, CT for former smokers, et cetera. We do colonoscopy. We do a lot of screening for cancer.
Yes.
What should we do for heart, and at what age? I mean, it's recommended you get an LDL checked as in childhood.
Yes.
And then repeat it when you're a young adult, and then repeat it, every 10 years thereafter. But what else should we do?
Well, I really try to hone in on what I'd say the first step a preventive cardiologist does, which is doing the, AHA-ACC risk score.
Yep.
As many folks know, there's a newer version that, based on larger data, called Prevent, as a new risk score. But I describe that as sort of the first step in a self-exam, because I'm really trying to empower patients here that I'd say, unfortunately, many have never really heard about a cardiovascular risk score. It's not something that their doctor has mentioned to them. And yet, there are websites that most people now have access to their health record data. So that's a great place to start. But we've made it a bit more complicated for heart disease than cancer. It isn't just as simple, at this age, you get this test. We have, a bevy of factors that go into your risk score. We have these risk enhancing features. But the goal is, okay, at some point, as you cross into potential risk, then you have that shared conversation. If your risk is high enough, often that step is then statin preventive therapy. But many people fall into this intermediate risk zone where the data is quite powerful that a coronary calcium scan.
The 10-year risk between like 5 and 10%, where it's that mid zone. You're over 10%, you should absolutely.
Yeah.
Even over 8%, probably absolutely. But if you're talking 3, 4, 5%, that's not trivial.
Yeah, I mean, the current sort of 7.5%, particularly the U.S. Preventive Services Task Force, will say there's some benefit there. There's more benefit after 10%.
Yep.
But we know there are people down in the 5% range who will have early disease, particularly if they have risk-enhancing features. So some people may, want to start therapy then. Some people can be quite resistant to therapy. And I think that's, to me, how you personalize the therapy. Do all your numbers add up to actually these plaque tumors starting to grow in your heart? And so a calcium scan is sort of the main tool we have, obviously, with a lot of the work being shown here at the ACC conference over this weekend, CT angiograms and AI analysis to quantify plaque volume and sort of plaque characteristics is an emerging area. But even just the basic, once your score is above 0, you have atherosclerosis in your coronaries. And I think for many of us in most of the guideline pathways, that's the stage to say we can stop it or even reverse athero at that stage.
Well, and it's even interesting, our mutual colleagues at Stanford, people like Fatima Rodriguez, David Marin, they were actually trying to extract information from non-cardiac imaging. So you've had a CT, you've had a chest X-ray. How do you extract that information using artificial intelligence to basically assemble a calcium score?
Dr. Topol just had a post on this opportunistic AI. Obviously, the disclaimer I already made about working at Toku. We're, productizing research we had that I had been part of at Google, which was AI for retinal imaging. There's a Heart Association presentation in the 1960s that cardiovascular disease causes change in the retina, but it's really AI that's allowed us to sort of automate that. We can do basically a risk score prediction from your retina. But CT scans, I talk about mammograms, have breast artery calcification. There are companies developing the AI tools to pick that up.
So we're going to be able to figure out more and more from a population perspective who may have, atherosclerosis and then go on some sort of decision-making with the patient about, do you want to get on a statin? Do you think you need more imaging? Can you evolve your lifestyle? So let's go back to the specifics about the book, because you're a busy guy. I've worked with you for years. How did you find time to write a book?
Well, I think it took a while.
Tell us how long it took, because I think for people listening, it's always, I think, informative that a book didn't just appear. It took time.
It was over a decade ago that my father-in-law had his heart attack and sudden cardiac death. And I think most of that was these ideas that go around in your head. I'd periodically write some things down on pieces of paper. But I'd say it was about 4 years ago or so where I got serious about trying to figure out how do you publish and putting together, sort of a 30% draft of the book to get feedback. And then there was a lot of trying to lock myself in the back office in the house, dedicating a few hours a day, sort of an off-peak time to try to make progress.
Yeah, it's a labor of love. I mean, it really did take you a long time. And I know you thought about, we would talk about it at various things you and I were doing together. And it shows because it's very thoughtfully written. It's, as I said, I love the combination of story and data. And I think it does tell a story. How has it been received?
Well, it just came out at the end of January.
Okay.
So
maybe I was lucky enough to got my copy earlier.
Exactly. Yes, no, I got a few advanced copies, and I think I'd given you one early on. What's great is I've had a number of patients who come in and said they've read it and they really enjoyed reading it, really helped them learn a lot. So both sort of colleagues and patients have gotten positive feedback, which I'm very appreciative.
Any feedback from the cancer community? Have they felt like, hey, wait a minute, you're in our space, or have they been grateful because it calls attention to them as well?
Maybe I'll get some feedback from them, but I haven't. Maybe hopefully the positive feedback when I think I'd mentioned. So the proceeds from the book will go to the Heart Association and the Cancer Society. So
thank you for doing that. I should have noted that at the beginning, that all the proceeds, and you say that in the on the cover, that all the proceeds are going to the HA and the ACS.
Yeah, well, I wanted this really to be about getting the word out, empowering people to have a more modern understanding of heart disease, and to give them tools that they can do themselves and to work with their doctors around.
And their families. I mean, you also take a lesson from the cancer playbook, if you will, of support. I mean, cancer patients, it's a big deal to get the family support. We don't see that with heart disease, do we?
Right. I mean, that was sort of the corollary in the beginning, where if you wanted to get diagnosed with heart disease versus cancer, most people would choose heart disease, even though it kills more people than cancer. But if you wanted if you wanted high quality care, people associate that much more with cancer, where there's friends, family. There's a much stronger support system. We can learn from cancer of how to get more people to help you when you do, if you do get an unfortunate diagnosis of heart disease. You and I have worked in the digital health space. One of the things that really has opened our minds to is how behavior change is key. And when you try to reach directly to consumer and engage people in their health, and that's an area where people are often more motivated to do things when it's for their friends, family, loved ones than just doing it for themselves. So that's, I think, another way that a broader care team and involvement can help people.
I've heard it described by our colleague, Kevin Schulman at Stanford. He says that there are emotional diseases and non-emotional diseases. Cancer is an emotional disease. Heart disease largely is a non-emotional disease. Do we have to change that societally to really be able to go aggressively after heart disease?
I think that would be tremendous. I think that's really part of the message here is if we start thinking about it as a growth inside our blood vessels that can kill, can grow and spread, and, in some ways, in scarier ways than cancer, it can be asymptomatic one day, like with my father-in-law, you could be dead the next. That if we approached it more like that I think there'd be a stronger buy-in among both the healthcare community and patients in treating it more aggressively.
So that's the message we are going to leave with, is that what we need is to mobilize the public health around this question of atherosclerosis.
Yes.
And be able to treat it aggressively like we think about treating cancer.
Right.
So,
but early, not just late.
not when the disease appears, but long before that.
Exactly.
So I want to thank you, Mike, for joining me here on Medscape Cardiology and Heart.org. It's been a pleasure to talk with you. For those of you listening and watching, let's put the book up here, Fight Heart Disease Like Cancer, by Mike McConnell at Stanford University. And as Mike said, all of the proceeds from the book are going to go to the Heart Association and the American Cancer Society. Mike, thanks for joining me.
Thanks, Bob.